The topic that we are going to examine is called DiGeorge Syndrome. DiGeorge Syndrome is part of various immunodeficiency syndromes that affect the development and the function of T cells. This one is specifically based on the failure of the thymus to complete development. DiGeorge Syndrome, also called DGS, is characterized by the deletion of chromosome 22 and affects thymic tissues during embryonic development. Patients with DGS express symptoms of immunodeficiency, hyperparathyroidism, and congenital heart defects, although the degree of DGS varies between patients. As illustrated, this is a drawing of a normal thymus. In a normal thymus, you will have high T cell maturation, which will then proliferate through the body to enact the immune response. However, in a DGS individual, partial thymus development or no thymus development will occur, affecting the T cell levels in the body. This degree of variation in DGS between patients can be defined as partial versus complete DGS. In the case of partial DGS, low T cell numbers will be present, but they can still enact a normal response to mitogen. They have activated lymphocytes. These patients possess an incomplete thymus and promote full lymphocyte development. On the other hand, complete DGS is defined by low to zero levels of T cells, and they have no response to mitogen. This is due to the fact that there is no thymic tissue present. This leads to high levels of infection and requires aggressive immunotherapy. In this presentation, we will focus on partial DGS due to the fact that less than 10% of patients who have DiGeorge syndrome will have the complete deficiency of the thymus.
DGS can manifest itself internally as well as externally. This picture is a child with DGS, and some of the facial characteristics include wide set eyes, as you can see is lots of space between his eyes, and low set ears, as well as a underdeveloped chin, and a thin or narrow upper lip. Other physical symptoms could be delayed growth, difficulty feeding, failure to gain weight, poor muscle tone, and delayed speech development.
In a DGS patient, you have the lymphocytes developing in the bone marrow. They then make their way to the thymus, where they will complete maturation. After maturing in the thymus, they will proliferate around the body and enact the immune response. In a DGS individual, the T cell counts will be lower throughout the patient's lifetime. Previous research suggested that T cells in partial DGS patients declined over time. Included in this deterioration was CD3, CD4, and CD8 levels. However, recent data suggests that there is no long-term depletion in the population of T cells present in those with DGS. Although low levels of T cells are still present, this research has vast clinical applications in discontinuing T cell deficiency precautions in DGS patients with stable immune function. This T cell deficiency has vast implications in the regulation and function of B cells and tumoral immunity. B cells require T cells for effective function, however, they can still mature in the absence of those cells. And NK cells also fall into this category.
Humoral immunity is found in the extracellular fluids of the body. It's also known as secreted antibodies and the B cell immune response. DGS patients generally possess a mostly intact humoral immune system. They have normal to above average levels of IgG and IgA antibody present in the blood and mucosal membranes. This depicts just a part of the intestinal tract where in the inside of the tract IgA will be found in relatively good levels for DGS patients, and on the outside in the bloodstream IgG is found in good levels. And as stated before, they have pretty good levels of these antibody isotypes. T cell responses usually influence B cell response as co-receptors for a second signal. However, they're not always required for activation of B cells, so they still have good B cell or antibody response. Most patients with DGS can be immunized and have good response from immunizations.
There are several treatments available for patients with DGS, and both of these treatments will involve transplantation. The first treatment available is transplantation of a thymus, and the second treatment available is a bone marrow transplant. In the thymus treatment, MHC matching is not required. Thymus donors are infants that undergo cardiac surgery. Immunosuppressants are given to patients before transplantation in accordance to the T cell function already present. However, there is a danger of autoimmune response. In some cases, the thymic tissue was replaced by fibrofatty tissue, which initiated the death of the transplant patient. Therefore, partial matching of MHC is often done. Even though there is only a partial match between donor and host, graft versus host disease usually does not occur in these cases. For the bone marrow transplant, very close MHC matching is required in order to avoid graft versus host disease. If a good donor is found, bone marrow transplantation has the possibility of full restoration of the immune system. By functioning to replace the patient's bone marrow, with healthy bone marrow to produce memory cells that can function as effectively as T cells would function in a healthy patient. However, between these two treatments, there are problems with availability. In the first case, early diagnosis of DGS is required for transplantation. This diagnosis and transplant procedure must occur within 1 to 4 months of age of the DGS patient. Thymus transplantation can also only be done in the U.S. at Duke's University Medical Center, while bone marrow transplants are common in medical centers across the country. Thymic transplantation also requires fetal thymic tissue or cultured thymic epithelial tissue. The fetal thymic tissue comes from the patients undergoing cardio surgery and therefore is less available. Between these two treatments, they have a very similar survival rate, between 75%.
Other treatments besides transplants for DiGeorge patients include a variety of things. One of them being vaccinations with live attenuated viruses. Another one being calcium and vitamin supplements. There's also surgery for correcting physical problems like cleft lips, and the speech and developmental therapy to help with this as well. And intravenous immunoglobulin therapy, or like antibody therapy, is also helpful in cases where there is a deficient antibody. Most DGS patients can live generally normal lives with these treatments. Some prospects for future patients of DiGeorge syndrome, like separated into complete and partial. If for complete DGS, thymic tissue transplants are highly recommended. And for partial, the more common bone marrow transplant is recommended to restore immune function or T cell function. Also, autoimmune disorder can occur. In 10% of patients, they occur. Most common types of autoimmunity occur later in life for a DGS patient. And there are a couple types that are most common, and these include rheumatoid arthritis and idiopathic thrombocytic purpura, or also known as ITP. DGS patients also have a high probability for recurrent infection, like respiratory ones are the most common, but these are easily eradicated with antibiotic treatment.